Good evening, everyone, and welcome. I don't want to interrupt all these great conversations, but I'd like to get the program started. My name is Deneen Saccone, and I'm Vice President of Policy and Advocacy at the Cancer Support Community. I lead the Cancer Policy Institute, and it's truly a pleasure to be here with all of you tonight. We are so grateful that you've joined us in person and virtually for this New Jersey Patients Over Paperwork Roundtable. Tonight's program is part of our ongoing effort to elevate the voices of patients, caregivers, and healthcare professionals working to protect cancer treatment decisions from insurance interference. Next slide, please. Next slide. Thank you. Before we begin, I'd like to thank our partners who have helped to make these conversations possible tonight, including Blood Cancer United, the International Waldenstrom's Macroglobulinemia Foundation, and Cancer Support Community New Jersey. And I'd especially like to thank our sponsor, B1 Medicines, for their support with this important initiative. I also would like to acknowledge Jamila Watkins from our partner, Blood Cancer United. She will be up later to tell you about the exciting and meaningful work they do for blood cancer patients. When we wrap this evening, please be sure to visit her table to learn more. Also, we are joined by Courtney Lozano, who's the owner of Mosaic Wellness Consulting, LLC. Courtney has a long history working with CSC and previously served as the program director for our network partner. Tonight's topics can be emotional and may bring up some very big feelings. And so if you would like to speak with Courtney, she is available and sitting at the table in the back. Just to give you all some background, these roundtables are actually being held in 4 locations this fall. 2 weeks ago, we held our first roundtable in South Florida. Last night, we were in Boston. Tonight, we're here in New Jersey, and tomorrow we'll be in Dallas. And each one is designed to bring together patients, caregivers, healthcare professionals, advocates, and community partners to talk about the very real ways that insurance decisions like prior authorization, step therapy, and treatment denials affect access to care and patient well-being. The purpose of this program is simple yet powerful: to make sure that the patient and caregiver voice is not just part of the conversation about access and coverage, but is at the center of it. Next slide. For those who may not be familiar, the Cancer Support Community, or CSC, is a global nonprofit network dedicated to uplifting and strengthening people impacted by cancer. So that's cancer patients, caregivers, survivors, and their loved ones. Next slide, please. As you can see on this slide, our vision is that everyone affected by cancer, no matter who they are or where they live, they receive the support they need throughout their experience. CSC is the largest provider of social and emotional support services for people with cancer and their loved ones. Our programs are grounded in the understanding that cancer doesn't just affect the body, it affects every part of life. And our goal is to ensure that no one faces cancer alone. Through our network of more than 200 CSC and Gilda's Clubs locations in 50 markets in 30 states, along with our toll-free helpline, digital programs, and educational resources, we provide more than $50 million in free services each year to patients and families. Next slide. At this point, I would like to talk to you all about our New Jersey network partner, Cancer Support Community New Jersey at Gilda's Club. Cancer Support Community New Jersey is actually located outside of Atlantic City and opened its doors in 2003 as Gilda's Club of South Jersey. To Southern New Jersey, they provide more than 100 free programs per month of social and emotional support, education, and hope for people with cancer and their families. Psychosocial support is provided through a variety of support and networking groups, healthy lifestyle workshops, educational lectures, and social activities for people touched by cancer in any way. Programs include patient and family support groups, stress reduction, yoga, nutrition workshop, and educational lectures presented by regional licensed healthcare professionals. CSC New Jersey also provides a robust children's program called Noogieland, as well as tween and teen groups to offer both age-appropriate cancer education and support. In addition to programs at their clubhouse, they have online programming available to those in the state and at satellite and off-site programming in Atlantic City, Egg Harbor Township, Cape May Courthouse, I'm from Maryland, so I'm going to say Vinland, though it might be Vineland, and Mullica Hill. You can learn more by visiting their website at twcnj.org. Again, that's twcnj.org. Next slide. And so now I'm going to talk to you a little bit about the Cancer Policy Institute, which is the department I lead at CSC. So at CSC's Cancer Policy Institute, or CPI, our focus is on translating what patients experience every day and amplifying the patient and caregiver voice and policy making at the federal and state level. Because we believe that patient experiences, patient feedback, patient perspectives, and what matters to patients related to quality of life is really necessary to help make the policy change that improves access and equity in cancer care. Our work is guided by, like I said, voices of patients, caregivers, and survivors because they know firsthand what it means to navigate insurance denials, appeal decisions, and face delays while waiting for treatment to be approved. And we take those lived experiences and combine them with the evidence from our CSC Research and Training Institute. And then we use that information, the evidence from our Research and Training Institute and the lived experiences from the patients, caregivers, and survivors that we serve through our network partner locations to inform policymakers, payers, and providers about what truly matters to patients and what patients value. So whether it's on Capitol Hill, in state legislatures, or in meetings with regulators, our goal is to make sure that every decision from coverage to care delivery reflects what patients need and not just what the system dictates. And really, that's what tonight is all about, connecting policy to people. So when we talk about terms like step therapy, prior authorization, and treatment denial, we are talking broadly about very technical terms related to utilization management techniques. And I recognize that for some people this can sound very technical. But behind every policy, there's a person. Someone who's waiting for an answer, someone who's missing work, someone who's scared their cancer is progressing while their paperwork is being sorted out. And so our goal with Patients Over Paperwork is to shed light on those real experiences for both those living with cancer and those caring for them so that we can understand how these insurance rules play out in everyday care and to use these stories to inform better policies and stronger advocacy. Tonight, you will hear from healthcare providers who navigate these rules every day and from a caregiver who lived this reality. Next slide, please. Again, I'd like to say thank you to our colleagues across the CSC network, our advocacy partners, and our sponsor B1, whose support helps make these critical conversations possible. Next slide, please. And so before I turn things over to our moderator and the panel, I would like to cover a few housekeeping items. So the bathrooms, when you walk out here and you see our sign that says Patients Over Paperwork, you make a left past the pool and the bathroom will be right across from the pools. And we also ask that you please silence your phones. And if you need to take a call, we ask that you please step outside of the room where you can have some privacy. I also want to assure you that we will have a Q&A period with the audience following the moderated panel discussion. And to those of you who are joining us virtually, please know we appreciate your time and we'll ask that you put your questions for the panelists in the chat and we will read them to the panelists. Next slide, please. And with that, it's my pleasure to introduce our moderator for this evening's discussion, Linda Lindner. Linda Lindner brings more than 30 years of editorial leadership to her role as panel moderator this evening. She is an award-winning journalist and managing editor shaping business news across New Jersey. She currently leads content at binj.com, producing high-impact reporting across multiple sectors and earning a reputation for sharp editorial judgment and exceptional storytelling. Linda is known for her ability to translate complex topics for broad audiences. I'd also like to say that joining her tonight is Dr. David Gallinson from Robert Wood Johnson Cooperman Barnabas Medical Center, and a very special welcome to a caregiver, Michelle Ashworth, and we thank you for taking the time and sharing your story with us. So with that, I will turn it over to Linda, and thank you all so much.
Thank you. Thank you, Dean. All right, good evening, everybody. Thank you for being here with us. And I think we'll just dive right into this very important topic. It's not one diagnosis that you ever like to hear yourself get or a family member get. And I think that all of us know someone. If not an immediate family member, you know extended family members or friends that have been diagnosed. And you know that there are a lot of different stories that they come back with because they are just inundated with information and they're overwhelmed. And so we hope that you can walk away from this evening with maybe a little bit of something that will help if you ever have to deal with this conversation again, or if you're going through it now. So my first question will be addressed to Dr. Gallinson. Okay, as a physician, I can't imagine what it is like to deliver a diagnosis to a patient, for one. And for two, if they come back to you and say, well, the treatment that you wanted me to get, my insurance company says no way. So you must have a staff of angels and miracle workers that deal with all this paperwork and everything. So would you like to tell us first a little bit about yourself and your role at RWJ, and then go right into that?
Okay, thank you. Thank you for inviting me tonight to be here. So I'm a hematologist oncologist, and I take care of patients who some have benign hematology problems, some who have malignant hematology, some who have new cancer diagnoses. So like you said, often I'm the person who puts together the puzzle. I don't feel well, I had these tests, I had this biopsy, and I'm the one that puts together and maybe sometimes confirms their worst fears and then starts them on their journey.
And so along with that journey, okay, if you know your patient best, they've come to you, you've seen their scans, their blood work and everything like that, but when an insurance company will tell them you can't go with what your doctor recommended, the insurance company is just going off of the name of the type of cancer. They don't know your patient directly. How do you and your staff deal with that kind of a pushback, or what do you do to help get through the phone calls and help the patients who just don't know anything? They're coming to you for guidance, right?
Right. So an expression that's been used for a long time is in taking care of a cancer patient. In other contexts, it takes a village. So there's a process, and I'm the patient-facing part of the team, but behind the scenes, we have a staff, and if I want to start a treatment, there's an approval process. So I write the order, I initiate the process, and there's a staff behind me. Truly, in preparation for this meeting, I had to do some homework, and I'm going to use my homework here. So in order to, behind me, there's a supervisor. There's 4 staff members. There's a financial coordinator. And that's just for the IVs, and a different team that takes care of oral medications. And I rely on their expertise. And sometimes the physician has to be involved to push the plan through, or try to push the plan through. But there's a lot of effort, a lot of moving parts. some of the, and if we have to try to get a quick approval, there's a lot of obstacles that we have to anticipate and try to overcome.
And, okay, so those obstacles come across. And again, I'll just, do you hear directly from the patient, or are you waiting on your staff to tell you what goes on? And you have more than just one cancer patient at a time. So it must be also difficult for you to keep track of everyone, to know like how your staff is doing. Where do we stand with Mrs. Smith and her approval, because we would like to get her started on treatment right away. Like, so how do you do all of that together? I mean, your village must be amazing.
I mean, the good news is I have an amazing team, and I only hear about the cases that aren't getting resolved as quickly as I'd like. I have the way that my pod is. I have a physician's assistant and a physician nurse that are assigned to me, and they're fielding the phone calls and coordinating with the approval staff to try to see what is the update if things aren't going as smoothly as the patient would like. For this meeting, I have more of an appreciation for the obstacles that are going on in the background that I hope my patients, majority of them, never have to think about or worry about.
And that brings another point. The anxiety level to the patient is also just never a good thing for their own personal health. So, do you ever see a patient that, I guess, takes that news and just keeps like shrinking, or do you have advocates for them, or how do you help them through when you see like that they're getting discouraged from all of these setbacks that might be happening?
So the setbacks that you're referring to, I think it's what I lump under the category of financial toxicity, because the majority of my discussions are about the side effects from the treatment, the symptoms from their disease, but I can never discount the stress of the financial toxicity. So, I've been doing this for a number of years, so I can anticipate some of the things, but I can't put myself exactly in their shoes. I just have to empathize as best I can. So I know what the resources are, and I make sure that the resources that are available are being pursued, but truly a lot of it just happens. I have an amazing staff behind me, and the process that I just reviewed with my staff in preparation for this, I have more of an appreciation for the amazing people that are behind me taking care of this process. And other than if it comes to a peer-to-peer or a dead end, I don't have to get involved for the majority of cases, but it's frustrating every time where I hit obstacles trying to deliver on the plan that I've recommended.
Agreed. I believe we're just joined now by Anne-Marie.
Correct.
Okay.
Yes, sorry. Traffic.
Would you like to, Anne-Marie Sheftick, would you like to introduce yourself? And
Sure. So I'm Ann Shaftick. I'm a nurse practitioner at the John Thurr Cancer Center in Hackensack. I've been a nurse practitioner for over 20 years and an oncology nurse close to 40. So I have quite a bit of experience with a lot of the issues we have.
thank you, Anne-Marie. Dr. Gallinson, we'll come back to you in a little while, but another big part of that village is the support group, the advocates for the patients themselves that they live with, the family members. And we have Michelle, whose husband was diagnosed at an early age with CLL. Michelle, would you like to tell your story a little bit, please?
Sure. So my husband was someone that never gets sick, and then all of a sudden kept getting sick. But, work was busy, and he just kept going to urgent care. So when you constantly just go to urgent care, they're missing that, hey, you're back again. Until finally I'm like, babe, you got to go to the doctor. And he did, and okay, we've got elevated white blood cells. So, we started going down the path, and ultimately it was a CLL diagnosis at 39. So at the time he was diagnosed, it's like, I think he was 0.1% of the population based upon his age. We had one child, so we had our daughter, she was 2.5, and we're, talking about having that second kid, and then you get this diagnosis, and, his CLL specialist was like, if you want that second kid, you better hurry up and do it now, Because if he starts treatment, and you don't know when you're starting treatment on CLL, with CLL, it's wait and watch. So it's kind of you're going through that wait till you get sick enough to treat. So while he was in wait and watch, we had our son. And then during COVID was time to treat. So that was an obstacle in and of itself. But we could, I guess, I don't know if go down that path or we'll get there.
We'll get there, I guess.
Yeah.
I mean, you've just said so much in that little bit of time. You've really put it down in a nutshell. But some of the obstacles that you came across, other than COVID, other than young age, other than 2 small children, were you denied any of the treatment for him?
Yeah, so so he did get into a clinical trial, which was super helpful. We didn't have that stress about paying for the drugs. But because you're in the clinical trial, there are some other standard of care that do have to be, we do have to cover, we have to pay for. But prior to going into treatment, there was a concern that he was transforming to Richter's, so he needed to get a scan, which was denied. Lucky enough, the hospital that we were at, we're like, well, we can't wait, so we'll handle it. We'll deal with the insurance, but we need you to get the scan now. I can tell you that the hospital ate it because my insurance company never paid it. Luckily, it wasn't Richter's. But, that was one of the first hurdles. Through treatment, there was another denial of a scan that, again, I'm saying we were very lucky in that the hospital that we're at kept telling us just go for it, and we'll handle it, and we never received a bill. So I think that's very lucky. And then fast forward a little bit, treatment's done, but his immune system never came back. So his IgG levels were super low. And we started out with IVIG, I think it was like every 12 weeks, then every 8 weeks. So right now we're at an every 8-week IVIG. And at one point they coded it wrong. So it was wrong ICD code, it got denied. Again, we didn't get a bill, but I saw the denial. So in that sense, we've been very lucky based upon the hospital that we're at. I know that's not the case for a lot of people. And, so last year, our insurance had a lower out-of-pocket maximum, and this year that out-of-pocket maximum has raised, right? So now we're paying more, we're getting less, and we're really paying more out-of-pocket. And he hits those, with the IVIG, he hits those out-of-pocket maximums. And then the way that, some of these bills come unexpected because something that happened in January didn't get through insurance, and we didn't get billed till August, but then we had other stuff that happened in March that we got billed for, and then all of a sudden you've got a $986 bill, in September. What is this? And, so it's just, now it's let me keep on top of all the EOBs that are coming through or all the claims going through. I've got a spreadsheet to just to make sure, so you don't get those unexpected bills, but they come. Those bills come, and Sloan wants to get paid.
So how do you handle that as the caregiver? You can't plan for those, or do you have to try to plan for that extra out-of-pocket?
Yeah, you have to try to plan for that extra out-of-pocket. Plus, we've got 2 kids who are very active. There's travel sports, there's art classes, there's gymnastics, so there's lots of stuff going on. I max out the FSA because I know I'm going to go through that really quick anyway, so I might as well get it pre-tax, right? It's a little tax help. But you have to plan for it, and then the hospital we're at, you can do a payment plan. So you just do the payment plan and you get through it till next year. But even with the payment plan, you have to try to make sure that the payment plan, isn't lapsing too much into the following year, because then you've got other bills that you're going to pay, but at least at the beginning of the year, you got that FSA card. So that covers it.
Can I make some comments?
Yes, please do.
So working off of what you're saying is, compared to going to buy a car or any other item in our society versus going through healthcare, what you see is, if I'm going to buy a car, I know what the price is before I go home.
Yes.
You go to healthcare and you have your treatment, and there's a process where it gets pre-approved. And then there's this amazing phrase in insurance, and I don't know if it's beyond healthcare, is pre-approval is not a guarantee of payment, is one concept which I've learned. And another concept is You get approved, and then there's a copay or whatever the patient owes, and you don't know until the back end.
Yes.
And I don't understand that. The positive in your story is the clinical trials, and clinical trials are near and dear to my heart, and it's a great way for us to offer better than standard of care options for some patients, get the next great treatment approved, and in some patients it's a financial gift to patients. But I have a story of a patient of mine and a patient my colleague shared with me where in my case the patient had a very rare hematologic disorder. I reached out to the right specialist, I shared the case, and I said, oh, by the way, this patient has this insurance. Well, we're the only one that has this trial, we don't take that insurance. I don't know what you're gonna do. So this is one lousy story, and a different lousy story is a patient who's on their journey, they've gotten through the standards, and they wanna get one more line of therapy to give another patient some more time, and the clinical trial wanted to use one immunotherapy drug plus the study drug. The insurance company was only willing to approve a Me Too drug, and the clinical trial is like, well, that's not how the trial is designed. You can't just substitute, and then the patient therefore couldn't get the treatment that we thought was the best for them. So these are interesting obstacles.
So let me continue that thought for me, please, because that's very interesting to me. If that treatment that the insurance company, the payer wanted to have your patient take, and it wouldn't have worked, but they had to go through that step anyway before they could do another type of treatment. How long of a delay, and what kind of a setback does that give to you as the physician, to your patient? Not always a good outcome.
Well, at that point, this is a heavily pretreated patient. They've been through a lot of choices, and we needed what we thought was the best option going forward. And because the insurance company, the clinical trial will pay for the study drug, the insurance company had to pay for the FDA-approved drug. In some of our diseases, there's Me Too drugs, and they have their one that's on formulary and the one that's not on formulary. They wouldn't let us use the one that wasn't on their formulary, and therefore the patient was not allowed to go on the clinical trial, and then we had to offer a less effective FDA-approved option outside of a clinical trial.
Well, that's always sad. That's not what you want to hear. And have you ever been presented with two different patients, same insurance, but one gets denied for a treatment or not? Two almost similar insurance policies, but not the same kind of approvals go through. That has to happen often.
I mean, so the issue is I don't always keep track of what their insurance is, but that's a likely scenario. Just you never knew you're going to get. Someone has similar good insurance, the same treatment gets approved, and then denied, and it's just, I don't understand why.
Well, from personal experience with dealing with my elderly father had squamous cell carcinoma in his throat a while back, and when we started to deal with the paperwork, sometimes, and I was telling you, Michelle, earlier, you would get someone on the telephone from the insurance company and be like, you know what? Thank you very much, and hang up, call again, get somebody else, and more helpful, and then they would look into it a little bit, and it would be a coding error, or we could change this, or maybe your doctor didn't exactly put the correct number in front of it, or maybe it wasn't the physician, not always blaming physicians. There's always another route, but you have to be persistent.
Absolutely.
Correct.
And and it's not, don't take no as the answer right away, ever. Ask again, say, plead your story, be very vulnerable, because they're supposed to be there to help you. And hang up and call back and see who else you get, because that's happened on more than one occasion.
Same.
Well, and just to add to that, I think the younger population, who is probably a little bit more computer savvy or internet savvy, gets better results because they know they're not going to take no for the answer. But then when you get those, let's say 75 plus, who don't have that experience, and they'll just say, okay, I'll pay the $2,000 a month because I want to live. So that's the unfortunate thing, I think that I tend, and I'm sure Dr. Gallen said, we see a lot of, is they just do what they have to do to get through.
It's a very vulnerable population. The ones that have younger, energetic family members to help them are very helpful. But yeah, I do worry about my older patients who can't advocate. They're sick. They don't have the energy.
Yeah.
It's tough.
No, definitely. And like just to piggyback off that, separately, my mom was diagnosed with mesothelioma like 9 years ago. And, you know, my parent, like they needed the help. And, you know, my parents were together since they were teenagers. So the two of them in the doctor's office came out of there with more questions than answers. So I started going to appointments with them. You know, you need someone to add, when you're in that situation, you're older, you need someone, you always need an advocate, but that specific population, totally, like they needed that help. And then we found the best specialists. You know, we're lucky enough that we live close to Manhattan, New York, New Jersey, all the specialists around, and you know, we made it happen. But you need to be persistent, and you need to advocate regardless of what type of cancer it is.
Anne-Marie, what about you? Have you had any experience with finding out like how to speed up the insurance process a little bit when a patient needed treatment like right away and it wasn't getting approved?
Unfortunately, years ago was a little bit easier because I used to do a lot more of it. Now we have a team that does it, but so it makes it a little bit more difficult, and I don't think that the insurance companies want to hear. I mean, I get on the phone very often and just say, I need this now, and I want a peer-to-peer immediately, and I want a peer-to-peer with an oncologist. Because when we do peer-to-peers, we often get anybody off the street doing these peer-to-peers who have no oncology experience. So it really makes it a little bit easier if they allow us to speak to. Sometimes there's a delay in that as well because they have to find the oncologist that we can speak with.
Gotcha. And Dr. Gallison, this is for you. Is it a pet peeve of yours, or do you appreciate when someone comes into the office, the advocate usually, and says, oh, I Googled, and this is what I found. Yeah. I was on WebMD, and you know, it said this, this, and this. So do you
So I usually try to cut the patients off at the pass. I start them with, what did Dr. Google say, or tell me what you Googled before you came in, because I assume that that technology is there and patients are going to use it, sometimes to their benefit, sometimes to their detriment. So I want to know, I can frame my thoughts, frame the conversation based on what the fears that they bring to the table, maybe some misconceptions, or build on what they learn that's already accurate. So instead of, well, I like to know what they know, and then I can build on that.
Okay, that's a good answer.
Well,
Very,
can I
yes,
just-
go
so
ahead.
especially with CLL, right? So when my husband was diagnosed in 2018, it was kind of like a time where some new drugs were coming out, novel therapies. If you Googled, you saw some very, very awful results. And it was, I stopped Googling very quickly. And then we just relied on, you know, for a while, just relied on the doctor. And then I'm like, oh, you know what? When I'm trying to decipher a study that's basically in another language for me, I should make sure that it's not from, you know, 2005, because it's a lot different 2018 forward. So that's also another thing too. Google can take you down a very dark and scary path if you don't know what you're looking at.
Absolutely. That's why I would
Yes.
ask the question that way. Emery, you mentioned peer-to-peer. And a lot of times, do you not actually get someone who's your peer on the other end of that phone? Okay.
Yes. I mean, when you do the initial call, you're getting someone who goes through a script of questions, and it's yes, no, and if you try to sort of yes because or no because, no, the answer is yes or no, sometimes they'll tell you. And it's like, but you don't understand, there's more to it than the yes and no. You know, but yes, it's difficult, like I say, when you speak to a radiologist who's trying to improve your chemotherapy, or even a pediatrician who, you know, if she's a pediatrician, a pediatric oncologist, well, maybe she has some understanding, but often, you know, you're talking to just some general doctor who has no oncology experience. So it makes it a lot more difficult in doing the peer-to-peers.
Can I comment?
Yes, please.
So I agree. So we talk about, you know, you hope to get a specialist who is your contemporary, who's got your level of knowledge. And, you know, I kind of put some thoughts down. And you want this conversation to be what is best for the patient, not as what is the most cost effective, because I feel like they're always often pushing you to what's more cost effective. And I'm sure you're familiar with the NCCN guidelines, the National Comprehensive Cancer Network. And we know that the organization is advocates for patients and doctors and puts together guidelines with, I mean, just to define what this organization does is it's the top cancer centers across the country, puts 30 some odd representatives to give guidelines for the top cancers, and it gives treatment recommendations with levels of approval. In my mind, if the NCCN guidelines has given a good high level of evidence to support this, that should be enough that the insurance company should pay for it. But now you're talking to someone who may or may not be an oncologist, then their company doesn't abide by the NCCN guidelines. They have their own internal guidelines, their own internal formularies, and we're playing a cost game as opposed to an evidence-based advocating for the patient. I mean, my wish would be is, there's not one right treatment for every patient necessarily, and that's a good thing. There's a lot of times these peer-to-peer should be, let's think what's best for the patient and come with it, but maybe you'll come up with a better treatment. That would be a wonderful peer-to-peer, not I say no and now go figure something else out.
Right.
Let's come up with a reasonable plan that's going to give us a reasonable outcome. And that's not what it really is.
And, cost effective in the payer insurance's mind, is it always cost effective? Not
Well,
if it's not the first.
If the disease isn't controlled and they're hospitalized and sick, they don't think about those kind of costs.
Right.
Correct.
Right. And then in the long run, if that first treatment didn't work and they have to go with a different treatment anyway, the one that they should have started with, it would have been more cost effective to go with what was most effective, right?
Correct.
Okay. So it's, again, to you, I'm sorry, Michelle, but I put you on the spot a lot.
Go for it.
And I asked you this privately before.
Yeah.
I asked Michelle if her husband likes to come out and do the talking, and she said no.
Absolutely not.
So it is very vulnerable when you're there and you're sharing your own personal story, and it makes everyone else, open up a little bit more and become not empathetic with you too, but they're learning along the way. So is there like one thing that you would recommend for anyone with a diagnosis
Yes.
that they should, do or get involved?
Yeah, I'll say when he was first diagnosed, it was a dark time, right? We were 39, he's diagnosed with this cancer, and the first doctor told us over the phone after she had told us that, hey, you know what, this is probably non-Hodgkin's lymphoma, this will be in your rearview mirror, and then she calls us, and after the biopsy, oh, by the way, it's CLL, over the phone. It's not curable, but it's treatable, and you've got an appointment in 2 days, so we can talk about it then. What? So dark place at the start. I am, you can't tell from now, but I am an introvert, and it was tough for me, and him too. It's his diagnosis, it's happening to both of us. Ultimately, when I started talking about it, and I got involved with now Blood Cancer United, but they were LLS back then, started doing a lot there. I signed up to be a first responder caregiver, meaning I get to talk to other people about what they're going through, and I'm paired up with someone that's similar. So I'm not a talker, but I am now. I wasn't a talker, but I am now. So that was super helpful. It helps to talk about it, hear what other people are going through, know you're not alone. And even, when I'm chatting with these folks and they're telling me, wow, you helped me so much, thank you, you have no idea, with this 45 minutes, it was so great. But they helped me too, because I'm talking about it. Husband, polar opposite, he will worry when Dr. Thompson tells him to worry, and that's that, right? So 2 different paths, we deal with it differently. He doesn't want the disease to define him, and I get that. But for me, I need to research. I want to know what clinical trials are out there, and what doctors we should be seeing, where we should be going, where his old doctor went, that kind of thing. So different paths, but you deal with it the best you can.
And Dr. Gallinson, for you, a question. When the patient might be my elderly father, he goes in there and he just hears and he's just like, okay, okay, okay. But when my sister or I go in there, especially my sister, man, she's ruthless. She is really, and she's like on that doctor, and I just, like, I pull her reins back a little bit. Like, there's only so much this man can do and tell you. You know, how do you calm those poor advocates down a little bit and, like, tell them you're there to help your dad, your patient, your, you know, your best interest?
Sometimes to try to anticipate how the family dynamics are going to go, if I want to tell a patient news, I almost never want to give news one-on-one. I want them to be with their support person. Can we make a time where we're together? If there's someone who's out of state, can we phone a friend? So if I engage them earlier, ideally at the first conversation, then they're not coming in the next conversation with so many questions and concerns. So try to get them involved early is the best I could do. And if that doesn't work out perfectly, I just need to be as empathetic as I can, because it happens to the patient, it happens to the family, it happens to the friends. Cancer just doesn't happen to an individual.
Right, that's right. You're not alone in it, and you need support. You have that. If it's not your own family, there's plenty of support groups that you can go to. Anne-Marie, do you have anything that you'd like to say about patients? And
No, I think I agree. It's really getting them in the very beginning to trust you and developing that relationship with them that makes it a little bit easier as time goes on. New conversations have to happen, whether it be treatment related, end of life care, things like that. So I think, and again, trying to really get that significant other or family or whatever around as much as you possibly can and involve them, because how many times we see patients, you know, it's the elderly husband and wife and no children to be found until things start going downhill, and then all of a sudden everybody pops out of the woodwork. So I think really to engage them much earlier, if you can, is always a positive.
thank you for that. Yeah, that makes good sense too. Let's see, where should we go now? Out-of-pocket costs. They keep rising, right?
Indeed.
And I know that we've said it a couple of times here, the financial stress and burden on the families, on everybody. And you don't know, walking into an office, you don't know the EOB, how much it's going to cost. It's not cut and dry. Do you ever, have you ever like refused treatment because of a price? Have you had a patient say, I can't take that, I can't pay for this? Dr. Gallinson, you can answer that for me if you don't.
So, yeah, that has been a challenge. And it usually plays out. It's a family meeting, and there's patients on board for treatment until they hear the cost as it plays out. And I said, I'm not going to survive this. I can't leave this burden for my family. I'm not taking treatment. And then you watch how it all plays out. It's very hard to watch.
That sounds like it is too. I'm very lucky that, you know, some people have good health insurance, but not everybody has good health insurance. That's our dilemma here in this country today. The health insurance costs are just skyrocketing, and it's hard for anyone to even go and find out that they have something. They live with a disease for a long time because they haven't had the coverage, and then all of a sudden they'll go into a doctor's office and get their test, and they're like, oh yeah, okay, I knew I was dying, you know, or, you know.
Yeah.
What patients may not know, and I didn't really appreciate that till I've changed practice settings, is it, I don't know exactly why this is, but going from one practice setting to another, the cost, the out-of-pocket changed. I had a few patients that tried to follow me from one practice setting to another, and the out-of-pocket escalated from the same treatment, same diagnosis, same insurance. From one practice setting to another, the out-of-pocket escalated. So I don't know how to help patients navigate that, because again, it's not like at the car dealer, here's what it cost.
Right.
They have to, I mean, maybe there's someone behind the scenes that could help. But,
Yeah, but how are you to know that you know, one hospital has a better deal with Aetna than another hospital? You know, it's
Well, your pharmacies are the same way. You
Yeah.
go to one CVS and another CVS, and it could be a couple, you know, $100 difference. So yeah.
Yeah, that's true too. Now you just touched on the other point. The medicine, the take-home medicine prices are all different too. And every time that comes up, insurance, I know, doesn't always approve all of the prescriptions all the time. You have to wait until the one is finished, and you're running, like, how
Right.
get it in there on the very last day to go in and pick it up. I know it's all a daunting
I mean-
scenario, the whole from start to finish, and you're never finished.
Yeah, and I'll tell you, like, when I saw the first explanation of benefits for IVIG, I almost fell on the floor. I'm like, wow.
Yeah.
It was insanity. If we didn't have insurance, we would not be getting IVIG, because if you don't have insurance, then you don't get that discount that the hospital gets.
Right.
So then you're, instead of paying, whatever thousands that my insurance is covering, you're paying the full 18,000. Who could do that every 8 weeks? Not us, not me.
What was interesting, something that I had seen earlier, is there's good insurance, maybe someone who has got a teacher in a union, there's the average insurance, and then there's charity care. There were some times when patients who had charity care, it was the easiest time, because they never got any bills, and things just got paid for. So sometimes no insurance was better than bad insurance.
Oh my goodness. Wow.
And then too, there's also, back to the drugs, like a lot of the a lot of the companies have grants. You can get copay assistance, you can get drug payment assistance, but you have to be able to navigate that. And I think the doctor's offices probably help with that a lot. But
Well, you have to be able to navigate that, and your patients need to be able to verbalize that, because a lot of times, out of embarrassment, they don't want to say, I can't pay for this. They may not want to come back for treatment, or don't know how to approach that. Anne-Marie, have you ever had anyone like confide in you because they're your close patient?
You mean as far as I guess because I had done it so much in the past, it's usually a question I ask patients when starting a treatment. Like even today, I had a gentleman who I needed to start a prostate cancer drug on, and he unfortunately doesn't have insurance. He's a charity care, so to do things in the hospital, it's fine. But when I have to give him an oral drug to take home for his treatment, he can't get anything. And a lot of the drug companies now, especially when they're older drugs and they come off patent and other drugs become available, they don't offer patient assistance. So now I don't know what I'm going to do with him. So we do have a couple of pharmacies that we can work with, including the Mark Cuban. I forget the name of that one, but the Mark Cuban, he does offer some drugs at a much cheaper discount. As well as there's a local pharmacy that has worked with us in getting this particular drug at a discount for some of our patients. But still, you're still talking $150, $200 a month for a medication that they have to be on for somewhat indefinitely because to control their disease.
So yeah, it's the Mark Cuban, the cost plus drugs.
Okay.
We can Google things, so we don't have to.
Dr. Google.
Well, Anne-Marie, you're part of that village that we began our conversation talking about, because I guess a lot of times, and I'll thank you for doing all that for your patients, because sometimes the advocates get a little impatient, thinking, they're not doing anything. They're not making these phone calls for us behind the scenes, but you are really working hard, and, we applaud you for that very much.
Well,
so,
thank you.
We have very, very little time, 2 minutes, so I'll start with Dr. Gallinson first to go recap. What would you like to let someone take away from this talk this evening?
So I want patients to understand that you're allowed to be impatient, but there is a process going on. The approval process takes longer than average or longer than they like. Understand that there's a team. There's a multi-step process going on in the background. We're submitting clinical data. We're submitting research to try to get the plan approved. The delay doesn't mean that we don't care. We're trying to shield you from the stress, knowing that there's uncertainty in the process, but we're hoping to help you avoid some of the financial toxicity, and there's a team of people working behind me to help towards that goal.
Thank you. Michelle.
Yeah, advocate. Know that you're not alone. There are people that are going through the same thing you're going through, even if it feels like there's not. There are. like I said, advocate and just try to, you know, get involved or reach out to one of these organizations. So like with CLL, we've got Blood Cancer United, we've got CLL Society, Cancer, you know, the Cancer Support Community. There are so many organizations that will guide you along that path for insurance assistance, doctor assistance, finding the right specialist. Just take advantage of the help that is offered, even when you're in that dark place.
Thank you. Anne-Marie?
And I'm going to say advocate. Everybody has to advocate. I went to a conference this weekend, and I have to put a plug in for Cancer Care because they recently did a study across the United States. There were over 1,000 patients patients involved in the trial. And what they found is 75% of commercially insured patients are denied 75% of the time that a drug is put in for treatment. Medicare or the Medicare Advantage plans, about the same thing, about 70%. And then when we talk about Medicare, so a good number of our patients fall into that, I want to say it was like 55% of those patients are denied right off the bat. So most of them are approved within a week of that claim being submitted. It can take up to 4 to 6 months in some instances for a drug to get approved. So again, I think we need to understand that piece of it as well, or not so much myself and Dr. Gallinson, but patients, their families, because it's not always us. And like he said, we're doing what we need to do to really get treatments for these patients. They've gone through a lot just being told they have a cancer diagnosis. So this is one less thing I want patients to worry about.
Okay, thank you very much. And I think now we're going to open it up to the question.
Yes, thank you so much. So what we're going to do is we're going to allow our panelists to take a quick break, grab some water, and I'm going to bring up our advocacy partner, Jamila Watkins from Blood Cancer United, to give a few remarks.
And thank you for the conversation. Good evening, I'm Jamila Watkins, and I'm a volunteer with Blood Cancer United. Thank you for being here this evening, and to this wonderful panel again, and to Cancer Support Community for bringing us together. At Blood Cancer United, our mission is simple but powerful. We aim to cure blood cancers and to improve the quality of life for patients and their families. We do that through 3 pillars of our mission, which include research, advocacy, and patient support, all of which have a direct impact on all the patients we serve, whether they're children or adults, newly diagnosed or going through treatment, or long-term survivors. Blood Cancer United is the world's largest nonprofit funder of blood cancer research, investing more than $2 billion to reimagine science and medicine to achieve breakthroughs worldwide since 1949. So as we've already heard, no one chooses to have blood cancer, and nobody wants their treatment to be a financial burden to them or their family. As we've heard, 47% of cancer patients and survivors incurred medical debt because of their care. 25% of adults say that in the past 12 months, they have skipped or postponed getting the health care they needed because of the cost. And 63% of adults with health care debt cut spending on food, clothing, and other basic needs. And so at Blood Cancer United, we've created an initiative tackling medical debt and the Medical Debt Case Management Program. And so if you're currently facing medical debt, our Medical Debt Case Program offers free personalized assistance to find options to help manage it. Medical debt case managers will work with you one-on-one to identify ways to reduce your current and future debt by addressing financial concerns, identifying resources, assisting with insurance plan evaluation and enrollment, and navigating insurance benefits, denials of care, and out-of-pocket costs. If your medical debt has become unmanageable, our Medical Debt Case Management Program can help empower you to address it. So I put some materials out front. I have some more materials in my goodie bag in the corner there, and I'm happy to share. So thank you again.
Thank you.
Thank you.
Thank you, Linda, for all that you do and for sharing all that wonderful information to advocate people with blood cancer. So what we're going to do now is turn it over to Linda to moderate the question and answer session. So if you have a question, just raise your hand. It's a pretty informal group, and I'll hand you the mic. And for those of you online, please feel free to continue to put your questions in the chat, and we will ask those questions on your behalf. We have a question from online, so I'll hand it over to Ivy.
So what is the best way for a patient or caregiver to be in touch with their healthcare provider and team while they're working, their insurance is working through denial or an appeal? Should they call, make an appointment? What would you recommend as the best way to do that? And I look.
Yeah. So for me, I found that the call wasn't always the best, right? Busy office, doctors in clinic, people are busy dealing with all their other patient issues. So I used the portal. I found that the portal was always the most quick and efficient way, and you've got a trail too, versus a conversation. You have that paper trail or electronic trail, however.
I would agree, the portal, using the portal to communicate with the doctor, nurse practitioner, staff is always the easiest.
Yeah, because a lot of times you call, and then they just have to call you back anyway. So just put it in the portal. When they have time, they'll look it up, answer it, and you'll get your answer.
Thank you. Do we have any other questions online?
We have a few more.
Great.
Yeah, I have a couple. One question was, what advice do you give families who are trying to about how to stay organized with, kind of navigating this whole journey with, the cancer journey, but also really the financial piece?
So when I try to meet with a family, I try to identify who might be the point person and recommend that if there's one person that is the first person to call and the first person. So if I have a family I'm getting multiple family member phone calls, it's distracting and some of the messaging is disjointed. So I think identifying a point person is very important, both to be the recipient of information and the one who calls. I think that offers the best continuity of the flow of information.
I'm like super organized, and I'm very, I guess, type A. I have a folder on my computer labeled CLL. We've got subfolders with every year, and I have spreadsheets. That just helps me. I try to keep.
And I will say, in my family, my sister is the organizer, and the rest of us just go off of what she says. However, there have been instances where that's not a good thing, because when you only have the one person who knows, but then something happens and the other ones might be there, we're like, oh, I don't even know what medicines they're on. I know it's in his card, in his wallet. Here's all the medicines, and then they rattle them off, and they're all foreign types to me. I don't even know. And like, it's the blue one, it's the pink one that he takes, things like that. So everyone really does need to be kind of on the same page, or at least know where to find the information to relay to a physician or to help.
Was there a comment that you?
Yeah, I was just wondering if when you talk about the point person, and I just know like caring for older people, like sometimes it's a healthcare proxy, like do you actually have that conversation? Because like I know when you have multiple siblings of like older parents, that it does get hard to try to communicate with the whole team. So like, do you just let them self-appoint who that point person is, or do you have like more recommendations about how like decisions are being made if there's someone that's like older, like going through the care?
Right. So I have to take into account there's individual family dynamics for every situation. So if we're talking about how, if I have to make a phone call to one person for an in-between comment or receive, but a lot of times you have to have a meeting where here's our next office visit. We're going to get everyone involved at the office visit. I was thinking the point person is more for the in-between office visits, But so a lot of times at the office visit, I just need to speak to the whole family each time, make sure everyone gets their questions answered. Here's the answer, so there's not the telephone game of information going in wrong directions.
We have a comment or a question from Courtney.
Thank you. I just wanted to mention regarding the support. I know our caregiver today was mentioning, talking to someone else who had kind of been in those shoes, who's, walked down that path. I think that's really important to just recognize that sometimes we feel isolated and alone, and we feel like no one else has been through this the way that you feel. That it's so overwhelming. So I just want to kind of reiterate that there's kind of like 3 paths to gain support. It could be peer support, like going through, talking to someone else who's been through it. It could be a professional counselor, or it could be a group support. So it kind of just depends on what you're looking for. There's no right and wrong, but there's so much available through the cancer support community. The calendar of events, no matter where you go nationwide, is wild. There's so many things offered. So take a look at that. I've actually had an oncologist say to me that, giving bad news is never easy, and he always said, I use your calendar of events to make sure, like, when I have to give bad news, I always say, but also there's programming and support, and just kind of like making sure that there's some kind of bow to tie at the end of that conversation. So thank you.
And to kind of build off of what Courtney said, and so in the line of work that we do, we talk quite a bit with patients, caregivers, and survivors. And one thing that stands out with me that I think makes CSC pretty special is I was speaking to a multiple myeloma survivor last week, actually, and he said, I have a great relationship with my oncologist. He's like my family, right? Because he's been helping me manage this since 2013. And he said, but what stood out to me is what was missing in my care journey was the mental health aspects that were just so overlooked. And he said that's just a real that's an area in our healthcare system where we're not really helping people impacted by cancer get those resources and get that. And so I kind of wanted to ask each of you, to the extent that you're comfortable, have you had that experience or observation where someone may be able to benefit from some mental health or psychosocial support? And if so, as a physician or as a nurse practitioner, how do you go about having those conversations, and how do you help people feel that type of support? Because he basically said I had to do it on my own. I found out on my own how to get the mental health support I needed.
So clearly in healthcare, mental health care is an unmet need across the board. I mean, we have a society where you have a symptom, we have a pill. We're talking about cancer patients who are already on a cocktail, and you're adding one more pill and another set of potential side effects. A lot of therapists, psychiatrists, they don't necessarily take insurance, so there's a financial obstacle to getting care. And then patients are over-programmed with their chemo, with their labs, and to have one more appointment, one more visit. I don't have the perfect answer. I'm aware that we don't do it as well as we could. I feel like each healthcare system needs to commit more resources to this. It's a big challenge. I think it does. I do have an awareness. I do discuss it, but I don't know that I have always enough resources to help the average patient.
I can also say to that point that it's no two people go through a cancer treatment or any kind of an illness the same, and neither do their advocates or their support group. It's you might have 10 people in a family, and one will break down, and it might not necessarily be the spouse or the child of it. It might be somebody else that's just like extended. So you don't really know at what point who needs the help, the mental health help. And you have to kind of rely on the rest of the family too to let you be aware of that, because at any given time that one person could just go like, okay, I don't know what was wrong with me, but it helps that I talk about it. So maybe just coming to another session or an advocacy group or a support group would be their mental health help that they need. You don't know. It's a very difficult thing to navigate for sure.
We actually have Another question online. For anyone on the panel, what's one piece of advice you would give to someone newly diagnosed and just starting the journey of navigating insurance on top of emotionally coping with their new diagnosis?
Yikes. That's a big one, because the diagnosis in and of itself is hard. And then you have to think about the financial aspect of it. You don't want to think about the financial aspect of it because now you're worried about, do I have to tell my kids? Is there treatment? Oh my gosh, it's chronic. What does that mean? So you have to navigate all that first. I can tell you for my husband and I, the dealing with the diagnosis was rough, but you immediately have to deal with the financial. So I started, looking at LLS at the time, Blood Cancer United now. There was a lot of information on doctors, hospitals, and insurance, and where you can get help. And then I dug deep into my healthcare insurance. Like, you never really go to that website unless you're looking for something specific. That was the time I was looking for something specific to see how we were covered. And even then, you're not sure. It's kind of, you don't know what you're looking at half the time.
And to answer that question too, no question is a dumb question. So if a new patient has a question, ask it. And keep asking other questions too if you're not satisfied with the answer, because you don't know what you don't know.
Yeah.
So you have to keep on searching and try somebody else, or not always Dr. Google, right?
Yeah. Also, what was super important too, because the diagnosis is throwing you off. Anytime you go to a doctor, we always made a point, especially at the beginning, to write our questions down and bring them with us. Because you get in there and you have 10 questions, and all of a sudden, you're reviewing the blood work you just took 30 minutes ago, and it's like, oh my gosh, I can't think of anything I wanted to ask him right now. So definitely write that down, whether it's insurance related, disease related, just write it down. Or I like to write. People just want to put it in their phone. So put it in your phone, make a note, write it on whatever it is, just have something. So you don't leave with more questions and answers. Then you're going to get to the car and remember what you wanted to ask.
I think when you have a new diagnosis, among the thoughts you have going through your cancer journey is, do I like my doctor? Do they have a supportive staff around? So you're assessing the doctor and the staff around him. Know that you don't have to stick with the first doctor you meet. Know there's other specialists in the area. Well, especially where we live here, there's multiple. If you live in a rural area, you might not have as many options. But you're allowed to explore. Don't worry about the doctor's feelings. You could explore. We're used to this. Patients shop around. It's fine. Advocate for yourself and put yourself first.
And second opinions I think falls under the same thing, because so many patients are afraid to get a second opinion that they're going to hurt our feelings. And the ego's not for us. It's, you need to make, like he said, you need to make sure you're comfortable with your healthcare provider.
Yeah, definitely get that second opinion. And when you have a certain type of, so like CLL, there are actual doctors that just do CLL, and that's who we found. Unfortunately, after being treated by this doctor for a bunch of years, he left. We had to start over, same hospital, but still, go where you're comfortable, where you feel, even if it is, and he was the second opinion. Go with whoever you're comfortable with, who you think is going to provide you the best care, what makes the best sense for you.
Sometimes the model that works for my patients is they come to me and every other checkup is at the specialist in New York. So you could, doctors can work together. You can navigate that as well.
Yeah, a lot of people do that.
All right. Gets back to Janine. Thank you very much.
Last call for questions for the panel. Don't be shy. All right. Okay. Hearing none, I would like to ask you all to join me in giving a round of applause and thanking our esteemed panelists and speakers for sharing their expertise and insights this evening. I think it was a very fruitful conversation. And so I would like to do right now is, before we wrap up our event, so we had this wonderful roundtable discussion all about patient voice, patient perspective, and sharing your stories. And what I would like to share with you, we'll have this on our website, but there's also hard copies out front, is our New Jersey Patients Over Paperwork Toolkit. And what this does is it basically does the step-by-step guide to help patients, caregivers, and survivors learn how to navigate, advocate, and get involved in the treatment decisions, how to appeal a decision. If, for example, you have a marketplace plan and you want to file a complaint, we give you information on how to contact your Department of Insurance. If it's a self-insured plan, we recommend you reach out to your HR administrator. And then we also give some sample text you could use when you want to have conversations with the insurer about a decision or why they had an appeal for a decision. And we also give information because we know your voice is powerful, and I've seen firsthand how your voice can really effectuate policy change. And so we also urge you, to the extent that you're comfortable, we provide some template language on how you can reach out to your member of Congress or your state representative to advocate for legislation related to utilization management, bringing down some of those barriers to care, related to copays, related to step therapy, and some of the other issues that we talked about with respect to pharmacy benefit management. And so I encourage all of you to take a copy with you. We will have this on our website, a dedicated webpage as well. So I encourage you to also go to our website, take a look at all of our resources that we have there, and to stay engaged with us, stay engaged with CSC headquarters, CSC New Jersey. We are here as a resource for you. And so as I listened to this conversation, there were a few things that really stood out to me tonight. What I heard a lot was advocate, advocate, advocate. And I can't stress that enough, the importance of standing up for yourself and not worrying about hurting someone's feelings. Be the squeaky wheel is what we say. Be the squeaky wheel, stand up for yourself, ask that question, because you know yourself better than anybody else. You know your body better than anyone else. And we know the importance of having some agency and having some control when navigating this journey. That's one thing that stood out to me. Another thing that stood out to me was the importance of having a community around you, particularly if you feel overwhelmed, about having those questions, having someone there with you to ask those questions so that you don't have to. So to the extent that you can, have a caregiver go with you. But we also recognize that not everyone has a caregiver. And so we actually had this conversation last night, and it was recommended that if someone does not have a caregiver, record the conversation with your doctor. You can record those conversations and have that information and go back and listen. And then the third thing that stood out to me that I thought was really important, don't forget to take care of yourself, particularly the caregivers, right? CSC New Jersey is here, offers support programs online, in person, having that community where you're not alone. And if there's anything that comes up that you might think, oh, I thought I was the only one that was feeling this way. And there might be a community where you realize I'm not the only one that feels that way. It's a unique journey for each person, and there's just not one way to do it. So what I also want to encourage everyone is, to the extent that you can, take care. Don't be afraid to also take care of yourself as little or as much as it makes sense to you. And so with that, next slide, please. I'd like to thank Blood Cancer United. A major thank you to our sponsor, B1, and to all of you here tonight for making this incredible programming possible, and also to our virtual audience. We so appreciate you for making the time to be here, and I would like to say this is just the beginning of continuing these conversations. And so feel free to stick around, talk, network, share information, but this does officially conclude our program for this evening. Thank you all so much.